You're okay. Go ahead.
Hello, we are group number 8, and we're going to be talking about Medicare and Medicaid. And our trip is made by Leah, Esvaide, Abe, and Chad. I'm going to start talking about the history of Medicare and Medicaid. So, Social Security was implemented in 1932 in order to provide income for people in their retirement. President Roosevelt included health care insurance for the elderly in his original Social Security bill in 1932, but ended up removing it. President Lyndon Johnson signed Medicare into law on July 30th, 1965. This was part of what he called the Great Society. This was a program enacted by the U.S. Congress as an amendment to the Social Security Act on the initiative of President Johnson. Two of the principal goals of the Great Society were to eliminate the poverty as well as racial injustice. The Medicare program was to have been funded through payroll deductions from citizens, with the goal that those deductions will become part of a trust fund that will earn interest over time, grow, and be available when the citizens turn 65 years of age. This is why when we think Medicare, we think of taking care of the elderly. The bill led to Medicare and Medicaid. The original Medicare program included Part A, hospital insurance, and Part B, medical insurance. Over the years, Congress has made changes to Medicare and more people have become eligible. In 1972, Medicare was expanded to cover the disabled, people with end-stage renal disease, requiring dialysis or kidney transplants, and this was regardless of age, and people 65 or older that select Medicare coverage. Another example was in 2000, they approved to cover Americans younger than age 65 with ALS. On this second slide, we see Medicare has been changed from its original configuration to encompass 4 parts. Part A, called Hospital Insurance Protection, provides insurance for healthcare administered within participating hospitals and post-hospital care. Individuals are immediately enrolled in hospital insurance protection when they enroll in Medicare. Part A is primarily funded by the tax deposited in Medicare's trust fund. It is supplemented through the payments of deductibles and premiums from patients. The amount of the deductibles and premiums depends on the patient's financial status. Part B, medical insurance protection, covers medical care not included in hospital insurance protection, such as outpatient care, physical therapy, and medical equipment. Individuals pay premiums to enroll in Part B, and the remaining funds are paid by the government. Part C is also called Medicare Plus Choice, known as Medicare Advantage plans. This allows individuals to contract alternative medical institutions through the Centers of Medicare and Medicaid Services. For example, they have Humana Medicare Advantage, or Blue Cross Blue Shield Advantage, stuff like that. The Medicare Prescription Drug Improvement and Modernization Act of 2003 made the biggest change to the Medicare in the program in 38 years. Under the MMA, private health plans approved by Medicare became known as Medicare Advantage plans. These plans are sometimes called Part C or MA plans. Part D is called the Prescription Drug Benefit. In 2005, under the administration of President George W. Bush, a law was passed to include prescription drug coverage for the elderly under Medicare rather than continuing to allow it to be funded by Medicaid. On the next slide, we're going to learn about the history of Medicaid. And Medicaid is a health insurance program enacted in 1965 as well by President Johnson as part of the War on Poverty. Medicaid was federally mandated at this time, but the majority of its funding is derived from the individual states. It is jointly funded through federal and state resources and provides the largest source of funding for medical and health-related services for low-income people. It gives aid to those with low income. On the next slide, we can see the mandatory eligible groups. Um, the basic categories are AFDC, TANF, and SSI, and they're described here on the left. You can see what this means. Beginning in 1980, categories were added to include moderate income children and pregnant women. Medicaid covers many groups as long as they meet certain requirements that include age, pregnancy, disability, low income and resources, citizenship, and legal residency. The Children's Health Insurance Program, also called CHIP, was created in 1997 to give health insurance and preventive care to nearly 11 million, or 1 in 7, uninsured American children. Many of these children came from uninsured working families that earned too much money to be eligible for Medicaid. All 50 states, the District of Columbia, and the territories have CHIP plans.
How Medicare is funded. Medicare is a program funded federally, more specifically by federal payroll taxes, general tax revenues, and beneficiary premiums. It is dispensed by the Secretary of Health and Human Services. HCFA, also known as Healthcare Financing Administration, is responsible for the day-to-day managing of the program. Today, HCFA is called CMS, which stands for Centers on Medicare and Medicaid Services. This this picture given to us by the Peter G. Peterson Foundation is really interesting because we get to see how Medicare spending has grown. We can see that in 1970, um, Medicaid and Medicare was only taking about 5% of the budget, and 44 years later, we can see that 14% was by Medicare and 9% by Medicaid. And it's projected that in 2040, that 20% of the budget will be taken by Medicare and 12% by Medicaid. How is Medicaid funded? The Medicaid program is jointly funded by the federal government and states. The federal government pays states for a specified percentage of program expenditures, called the Federal Medical Assistance Percentage. FMAP varies by state based on criteria such as per capita income. This slide right here, although it took me a little while to try to understand it, but it's really interesting, and it helped me understand that although Medicaid costs in dollar terms increased in all states between 2000 and 2013, the effect on states' finances varied widely after factoring in how much money a state took in each year. And Medicaid in 2013 consumed about 1 cent less of each dollar raised by North Dakota, but at least 8 cents more of every dollar generated by California, Maine, and Minnesota. Only in North Dakota did Medicaid spending fall as a share of own source revenue. Medicaid accounted for 7.3% of state dollars in 2000 and 6.1% in 2013, a drop of 1.2 percentage points, a little more than a penny per dollar. The share declined because the state's oil boom pushed up revenue 175% over the period, outpacing the 131% increases in Medicaid costs in inflation-adjusted dollars. Medicare Trust Fund. Medicare is paid through two trust fund accounts supported by the U.S. Treasury. Hospital Insurance Trust Fund. How it is funded. Payroll taxes paid by most employees, employers, and self-employed citizens. What does it pay for? Medicare Part A, which is hospital insurance, example, inpatient hospital care, and Medicare program administration. Um, the Supplementary Medical Insurance Trust Fund. How that is funded. Funds authorized by Congress and premiums from people enrolled in Part B benefits and Part D. What does it pay for? Part B benefits, Part D, and Medicare program administration. When Medicare will become bankrupt. Congress has spent monies that should have been in the Medicare Trust Fund. There are insufficient funds to support the baby boomer generation. The Medicare Trust Fund is projected to become insolvent or bankrupt around 2030. Medicare's insolvency pertains only to Medicare Part A, which covers hospital care for the program's beneficiaries. Insolvency or bankruptcy does not apply to Part B or Part D.
Okay, this is Leah, and I'm covering some of the issues, current and future, that Medicare and Medicaid will be facing. And we start out, of course, with the spending, which, as Abe described, is not going very well. Medicare spending for 2015 exceeded $646.2 billion. It's projected to go from 15.2% in 2015 to 16.8% in less than 10 years. On the same vein, Medicaid spending for 2015 was in excess of $552 billion, and unlike the Medicare figures, this does include administrative costs. So I can only begin to imagine what the Medicare spending was for 2015 when you add in all the administrative fees. The federal portion of Medicaid, which some people don't understand, the average nationwide, the federal government contributes 62.8%. So they're contributing 100% of Medicare and 62.8% of Medicaid. So then we begin to grasp why Medicare Medicaid takes up such a big portion of the federal budget. Short and long answer is, though, that all of it is taxpayers' dollars. So the taxpayers are the ones footing the bill for this astronomical fee. The state portion average, of course, is around 37.2, and that varies greatly. Some states' contributions are in the low single digits compared to this average. So the thing about Medicaid is that the growth of the Medicaid program is driven completely by economic conditions and policy changes. So, for instance, now that we have a new president in, he's making some changes to the Medicare, Medicaid spending process, and so that affects how quickly Medicaid grows. So it's a little bit hard to determine at this point. Okay, specific Medicare issues that are on basically the top of the list are increased cost and administration for Medicare Part D drug plans. As SBA pointed out, it's the first major change to the Medicare program in 45 years, and with it comes all the issues and problems that have to be worked out with the new part of the program. The role of private plans or Medicare replacement plans is another big issue. There's a lack of control over fulfillment of those contracts. Timely and appropriate payment for Medicare approved treatments is one of the issues. Treatment availability declined due to lack of physician enrollment. Some plans have gone out of business because their payment was so low or untimely, or we're denying services that Medicare would have approved. So a lot of physicians would disenroll or not re-enroll at the end of the year. And so there weren't doctors to provide care for those patients that were under that plan. contract enforcement to protect the vulnerable. The difficult thing is that these Medicare patients or Medicare eligibility people sign up for one of these replacement plans, and they're not able to switch plans without somewhat of a fight until a year passes when the open enrollment season starts. So if you get into a plan and your doctor doesn't participate in that, you have to switch doctors. Or if your insurance company is not very reliable and they're not paying out the way that Medicare has said that they would, you're kind of stuck. So it's kind of a difficult situation for those elderly patients. The other issue is long-term care accessibility and cost. As the baby boomers are coming into their retirement years, along with the strain on Medicare, comes the fact that more and more people are going to be needing long-term care assistance, and that is a huge expense. And then, of course, ultimately, it's controlling the costs. Medicaid issues, of course, the controlling costs or the underlying problem here, but economic downturns, the biggest issue with that is that when our economy federally or statewide has a downturn, more people lose their jobs, more people's income drop, and more people qualify for the service at the same time that the revenue tax base is declining because there's less people spending money and less people earning money. State and federal policy is another big issue for Medicaid because you have the Obamacare, you have expansions to the Medicaid program either suggested as optional or demanded by the Medicaid or the federal portion of Medicaid if you want to continue to receive funding, and changes in the poverty standards. The other issue would be ensuring access to doctors and dentists. A lot of states, the Medicaid reimbursement rate is so low that you find that a lot of physicians, dentists, especially specialists, refuse to participate with Medicaid patients, or if they are participating, they will limit the number of patients that they will accept that currently have Medicaid. They do this by having patients fill out an application to become a patient there, and then the patients are left without physicians to care for them. Again, meeting the demands for long-term care, because most people that are in a nursing home or a long-term care facility are use up their funds fairly quickly. So if they're a Medicare recipient, then they roll over into Medicaid as secondary payer. Okay, the other main issue would be controlling fraud, waste, and abuse. According to an article in The Economist in 2014, fraud accounted for $242 billion in illegal healthcare spending. And this happens in several different ways. The first one being fraudulent eligibility. So you have people that haven't married, have children, they're claiming Medicaid, they're claiming that they don't know who the father is so that all of their hospital bills are paid, or they're living together unmarried and they're only claiming one income, or they're getting paid under the table, so they're receiving benefits when in reality they should be paying something for their insurance. Stolen identities is another issue. And then you get into fraudulent billing, where facilities, hospitals, physicians, care facilities bill for services that are either not needed or not provided. And this extends all the way into equipment, drugs, and therapies. When I was reading for some of these slides, one of the examples that they gave was a pharmacist who had fraudulently billed hundreds of thousands of dollars to Medicare for prescription drugs that she had distributed, when in fact what she was doing was she was purchasing the unused prescription drugs from the local nursing homes, and she was reissuing them to new prescription patients, and she was rebilling Medicare. So in a sense, she was getting paid twice for the same medications. And then even giving the nursing homes a kickback, she was still making a huge profit. The other issue would be lack of control on the part of the government. Since the people that are receiving the treatment are not directly paying for the services, there is a disconnect with the patients receiving the services, but there's also a disconnect with the people administering the funds, because there's no incentive for them to really make a profit or be cautious. It's not their money, and they're not in business. So you combine those things, and it can create quite a sense of entitlement. Really, is what it all amounts to.
Okay, my name is Chad Barnabas. I will be discussing beneficiaries of Medicare and Medicaid. First, to start off, the definition of Medicare and Medicaid is Medicaid and Medicare are two governmental programs that provide medical and health-related services to specific groups of people in the United States. Although the two programs are very different, they are both managed by the Centers for Medicare and Medicaid Services, a division of the U.S. Department of Health and Human Services. Beneficiaries of Medicare. What is Medicare and who is it available to? Medicare is health insurance that assists in helping the nation's elderly to meet hospital, medical, and other healthcare costs. Medicare is mostly available to individuals 65 years of age or older. Although Medicare is available to patients 65 years and older, it is also based on medical conditions. If you receive Social Security for 2 years because of disability, you qualify for Medicare. Others who are also qualified for Medicare are disabled widows, widowers, or are child of a disabled worker. Those also qualify for Medicare. Medicare has also been extended to persons under age 65 who are receiving disability both through the Railroad Retirement Board and that is available to people who are in end-stage renal disease, no matter of age. In this slide, it shows you the Medicare population as of 2011, in which analysis of different ages, disabilities, incomes below, savings below, and conditions of persons and percentages of the nation's people who are on Medicare. And you can see on the chart that long-term care facility residents range of 5%, and the highest is 3+ chronic conditions people have. I found that very interesting when I was looking at this chart. Beneficiaries of Medicaid. What is Medicaid and who is it available to? Medicaid is a means-tested health and medical services program for certain individuals and families with low incomes and few resources. Primary oversight of the program is handled at the federal level, but each state also establishes its own eligibility standards. It determines the type, the amount, the duration and scope of services, and sets the rate of payment for services rendered. Beneficiaries, as of children under age of 6 whose family income is at or below the 133% of the federal poverty level. Pregnant women with family income below 133% of the federal poverty level. Supplemental Security Income, SSI recipients. Recipients of adoption or foster care assistance under Title IV of the Social Security Act. Special protected groups such as individuals who lose cash assistance due to earnings from work or from increased Social Security benefits. Children born after September 30th, 1983, who are under age 19, and in families with incomes at or below the federal poverty level. Medicaid is available to those that are qualified pregnant women and children. It also is available to some Medicare beneficiaries. But one thing I found interesting while reading through this is that Obamacare gave opportunity for the states to expand Medicaid to cover all low-income Americans under the age of 65. In this slide, the composition of Medicaid population, both by sex and age, of 2011 shows you that men 15 and older, 20%, women 15 and older, 33%, and children under age 15, 47%, make up 58.3 million of all beneficiaries who receive full benefits, full Medicaid benefits. And the bar graph next to it shows that ages of women ranging from ages 15 to 49 show a larger percentage who receive Medicaid more than the 65 and older, or than between 50 and 64. That was our project. This is the works cited page. And I hope you enjoyed our presentation.